So, look, welcome to James Pollard. I think he's already been introduced. James is the Director of Hospital in the Home at Cabrini, which is one of our very large private services in Victoria, and has a very long track record in Hospital in the Home. And are you the current President of the HITH Society, James? Excellent. So we're in very good company. So, look, I guess we're really looking forward to your talk. I'm not sure what we're going to learn, but I think it's going to be very interesting.
Thanks, Ben. Look, thanks very much, and thanks for the invitation to speak to everyone tonight. Been to a number of these now, and they're always very high quality, so I'm quite privileged to have been asked to speak to you. I'm going to talk to you about broadly how HITH and OPAT has evolved, and then through how COVID has further evolved it, and I'm just going to run through that now. So we can only know where we've got to by knowing where we've come from, and basically, sorry, I'm just having some IT issues. We'll go to that one, that'll be easier. So care at home is not really a new concept. From ancient civilizations to modern times, we really have moved from a home calling doctor to one that really was largely hospital based, and that was largely driven by increasing specialisation and non-portable devices. And these technological advances dramatically improved outcomes, but unfortunately also took care away from where we know patients actually want care. And as a concept in Australia, hospital in the home really evolved trying to drive low acuity conditions out of hospital beds, which was primarily both financial and capacity driver. And after a pilot program in Victoria in 1994, it really rapidly rolled across both Victoria and then around the country. So those early services really focused on low acuity, low complexity treatments, and clearly the poster child at the time was cellulitis, uncomplicated lower limb cellulitis, and at that time it was also DVT, being in the pre-DOAC era. But typically, services were limited. They were simple, single daily visits with fairly narrow treatment options, and that really limited what services could do. And then we got a bit braver and we started measuring some of our outcomes and looking at different ways of treating, and there's kind of two fairly keynote papers in those early cellulitis trials, and the two keynote names on those will be well known to probably almost all the audience. Karen Leder published in MJA in 1998, and Lindsay Grayson later on in CID, really showing good outcomes of ambulatory care using simple antibiotic regimens. That led to departments of health having clear definitions, and that did take time, but they finally got there, and really providing care in the home that would otherwise be delivered within a hospital. And I think that's a really important delineation between hospital in the home and OPAT. OPAT can be ambulatory, it can be non-substitutional at times, but realistically, we're all talking the same thing, which is really giving complicated care. And the reason it's tied to parenteral antibiotics is because historically that was always within a hospital. And so the other states followed. New South Wales were next, Queensland and SA shortly thereafter, developing their own guidelines. And slowly, nationally, we came to a fairly combined understanding of what we were all doing. And so again, hospital substitution, New South Wales talk about access and ensuring equitable access and providing patient-centred care. So I'm not going to keep prosecuting these arguments. I think everyone watching tonight will understand all of these things, but just to re-emphasise that we are all talking the same language, whether we're saying hospital in the home or OPAT. But what differs is the way the models run, and some of them are driven by funding structures, some are driven by resource availability. And historically, there were services that were largely nursing-led, so hospitalists, hospital-based doctors would be directive of care, and then the nurses would be left to run unless there were problems. Gradually, a more medical-intensive and medical-led services evolved, and we decentralised and contracted models came to the fore, as did privatised models over time. Another really interesting model that was very strong back when I was working in Queensland was self-OPAT. So whilst you would have regular checkups with your treating clinicians through clinics and the like, you would actually be trained to self-administer OPAT. So it's trained to administer your own intravenous antibiotics, and really attractive, particularly for patients who would have regular episodes of treatment. So I'm thinking things like teens or young adults with cystic fibrosis and the like. And over time, we could actually then, with better delivery devices, so ambulatory pumps, elastomerics and the like, we could actually convert from daily visits. We could do BD or TDS visits, and we could do 24-hour infusions and or TDS dosing, or even QID or Q4 hourly, or whatever we needed. So we got a bit smarter, and over time, remote monitoring has come. I'll touch on that a little bit later. And just to acknowledge the rest of the world, Australia, you know, was some of the early adopters, but certainly all around the world. So the UK did a huge amount of work in OPAT, and the UK BSAC group, acknowledging a huge amount of work they did through the kind of mid-2010s, really getting this established and with clear guidelines, expected outcomes and the like. But at the end of the day, why are we doing this? Well, because our clinical efficacy is excellent, okay? So outcomes are as good, if not better. The cost is typically cheaper, but, you know, there's some caveats to that, depending on the complexity of what you're doing. And the patient satisfaction is very high. And I think Michael Montalto, who you know, is a fairly well-known hospital in the home clinician, really captured this really nicely. The 500-bed hospital that isn't there, and that's 2010 numbers, it's probably now an 800 or 900-bed hospital, and that is in Victoria alone. So it's a whole hospital that hasn't had to be physically built. I mentioned the OPAT working group, part of BSAC, really clear guidelines and a very thorough clinical review that was done in 2013. They were very much more cautious on some of the risks than some of the existing HITH guidelines, particularly with a more antibiotic focus and antimicrobial focus, and particularly around side effects, and particularly a focus on length of stay. And you'll hear later tonight about early oral switch, and I think that's something that we really need to be mindful of. Because it came out of the BSAC group, that interaction between OPAT and AMS, which is really critical as well. We shouldn't just be giving parenteral antibiotics because we can. It's really important that we make sure that we are focused on what we're doing. And this particular review was much more focused on the clinical conditions rather than the administrative requirements. And as you might imagine, the Department of Health guidelines within Australia were much more focused on the administrative requirements than necessarily the clinical side. So really, just to spell it out fairly clearly, it's not just a give at home program. You really need to understand, you know, the dosing schedule of what you're doing, the cost of drug versus a clinical time cost. Geography is quite important. You know, how far are your staff having to travel to deliver OPAT or HITH? The temperature in the environment that you're delivering, as well as the temperature considerations for the antimicrobials that you're administering. Shelf life compliance, patients need to be very compliant, and obviously the side effect profile of the drug and what you're going to do with that if there are complications or problems. But yet more so, the spectrum of activity of the antibiotics you're using. Why use ceftriaxone if you could use benzoyl penicillin? You know, understanding treatment durations, being able to monitor, so drug levels, creatinine, etc. Understanding the clinical review timelines, and really importantly, having a clear plan and managing unplanned returns. And so this was really 2.5 decades of work to spell out all of this, to have services comfortable in managing all of this. So by 2019, HITH or OPAT, however you want to describe it, was safe. It was well developed, but still somewhat of a cottage industry. So it was staffed really by a diverse range of HITH-friendly specialists or generalists. It had spread very much nationally, and Australia was considered world leading. And in fact, a number of other countries now have well-established HITH services. France have been doing this for a long time, as have Spain. The UK models are really gaining ground at the moment. And so the first World Congress was held regarding hospital in the home or hospital at home. And the Americans were getting interested as well and starting to publish. So we were going along nicely right up until COVID arrived. And then the pressure really came. So these pictures will be fairly familiar to everyone. So the well-known Ruby Princess and the huge numbers that came from that, the various nursing homes that had major issues early in the outbreak, and of course, the amount of resource that had to be put into preparing intensive care units and the doubling, tripling, quadrupling of intensive care bed availability in the early stages of the pandemic. And so in March 2020, it was clear that there was going to be urgent capacity, and suddenly everyone was an expert. Everyone had their own opinion on what needed to happen. Everyone was trying to design something differently. And with time, various different guidelines came out, but guidelines do take time. And I guess something I was really pleased to be involved with and really pleased that the society could support were some initial guidelines around the role of hospital in the home in COVID-19. And bearing in mind, this was written in March 2020, so there was a lot we didn't know, but what we did know were the principles of hospital in the home. Sorry, there we go. So really, this paper, and it's free to download, you can get it on the Hospital in the Home website. It's subsequently been published. And, really understanding the challenges and what the goals for HITH were going to be, and then considering how HITH would prepare and then what the clinical role was. And as all the things we've discovered during hospital in the home, some of our basic principles have served us well and some of them haven't. So really understanding what the volumes were going to be, who our patient targets were going to be, what we were trying to achieve in the care for them. And then obviously understanding our staffing. The staff were stressed, they were worried they were going to catch COVID, making sure you had processes and protocols in place. Equipment was a huge problem. I mean, oxygen SATS probes were just in scarce supply globally. The workload was becoming problematic for our healthcare workers, and that's really only got worse over time. So, and then really the one that our staff were most worried about, and certainly as a service manager, I can tell you I was most worried about, was minimising risk of exposure in those early days. We were seeing all the case reports and seeing cases of really bad outcomes with COVID-19 infections. So a lot of work into that. And then I was pleased that early on we remembered to put in about supporting each other, and that's really, critical in healthcare at the moment, is understanding that. And so we then described where the clinical role was. And of course, remember, this is the pre-treatment era, I suppose, pre-vaccination, pre-therapeutics, and really just some early comments on the interventions we knew we could sustain. So that's monitoring oxygen saturations probe, understanding how we would transfer them back to hospital if or when we identified deterioration. Okay. So that's what it looked like on paper in March 2020. What actually happened? Well, there was a huge variety of responses, and it varied between hospital to hospital and state to state to some degree. We suddenly had everyone interested. CEOs were ringing their HITH leads saying, how are HITH going to manage all these COVID patients so we didn't have them in the hospital, which in some respects was a great challenge, but in many respects was an opportunity. Suddenly HITH had some limelight. Various Medi hotels, so as opposed to hotel quarantine, Medi hotels were looked at as options as well, because patients didn't want to go home to their families. They didn't want to share it with their families. We did get very good at stratifying cases by their risk and their monitoring requirements. Again, that evolved over time, but really a lot of work went into that space early on. The PPE, access to PPE, and all the workforce challenges around, staffing services where, in the early days, people were scared. They were very scared of COVID, and it took a lot of reassurance that the safety processes, the PPE we put in place were going to protect them. The telehealth and the remote monitoring is a really interesting one, and it's a topic of a whole 20-minute talk on its own, but I think what we learned was that simple is sometimes better. So the high-tech monitoring equipment that requires all sorts of interventions doesn't necessarily work brilliantly in this scenario because patients are just learning to use it. They're often quite unwell. The really simple finger probe, the really simple phone calls, and having structure behind how you do them was important, but having NASA in the home wasn't actually that helpful. And I think I say all of this, the patient demand became really interesting, not so much in the COVID space, but in the non-COVID space. So in the old days of the soldiers at war who didn't want to go to hospital because that's where you became sick and unwell, patients were fearful that they'd become sick and unwell in the hospital. So they were demanding hospital in the home for all their non-COVID conditions. And of course, for this group, that was all the antibiotic associated treatments. And of course, this is all in the context of the global issues, and everyone was learning this globally at the same time. And when we think about strategies, there were clearly HITH-led strategies. There was a hybrid where a HITH service would engage with a non-HITH service, so a respiratory unit, an emergency department, about how they might run a program. There were standalone COVID programs. Some of the hospitals ran really, really high quality standalone COVID programs that never really touched their hospital in the home service, and they were very much a contact light service, but they were very, very effective. And then what also was an important strategy was scaling up all the non-COVID and other out-of-hospital services, so things like chemotherapy and rehab. And then we all got vaccinated and everyone got a bit more comfortable with COVID. And the treatments came along, and I know there's talks from Lydia and Kate shortly about some aspects and all of that. So I'm not trying to cover that tonight. But I think just the evolution was therefore into treatment of COVID, and there's obviously some barriers in some of these interventions in a home-based setting, and I know Lydia's going to talk to some of that, so I'm not going to cover that in any depth. But I think the one to really emphasise and remember is the non-COVID demand, and the non-COVID demand is sustained now. His services are really busy around the country at the moment, and some of that is the delayed elective treatments, so it's people having elective treatment now and the volume that they're trying to get through to make up 2 or 3 years worth. And it's the condition people are coming to hospital in because their elective treatments from 1 or 2 years ago has been delayed. And they're often in more deconditioned or similar states. The evolution towards nursing home avoidance, and that's patients not wanting to go to nursing homes because of the highly publicised outbreaks. And therefore hospitals putting in hospital in the home or community-based models to support people at home with significantly increased resource requirements to the baseline patients we were seeing pre-2020. And then capacity shifting, where we really have tried to capitalise on this opportunity where people are accepting and wanting care outside the hospital for their acute and subacute medical conditions, and are now demanding it rather than being, pleaded with to do it. So I'm not going to talk about home infusions, but there's been lots of models around the world. So this one's from the US. This is from the current Monash website, and that's obviously evolved over time as well. The non-COVID demand, just to put some pictures to that, and whilst it doesn't look dramatic here through 17, 18, 19, the system was really clinging along. So these are patients leaving the emergency department on time, and what you can see is obviously in recent times it's really driven down. And as I said, really important that we use home-based care in whatever format to help with some of these capacity issues. And again, there's a whole talk in the drivers behind all of this. So I mentioned the nursing home avoidance and the patients wanting to be in their own homes. There's huge demand on personal care providers at the moment, and they're having the same staffing issues that hospitals are, that your local cafe is, that supermarkets and basically everyone is at the moment. Their baseline condition before admission is often compromised as well, and really put a lot of resource to try and in-reach into nursing homes. The capacity shifting around the system, services are engaging, public care in private hospitals. I mean, it's all one system really at the end of the day, but that just comes down to who's funding it. This relentless drive to decrease length of stay in the hospital is clearly still a focus. The work patterns and what the work people want to do, people are burnt out and tired, and that's impacting their ability to support the system. The video conferencing and the remote monitoring. The video conferencing has been really useful in some settings, and some services have engaged that really well. Other services have found it really difficult to sustain, be that because it's unfunded, be that because they're remote locations and the technology difficulties. And the remote monitoring remains problematic, that the cost of installing it and the utility of it relative to, as I mentioned at the start, a safe and effective system that had been running for 25, nearly 30 years, you're putting in a lot of expense for a very minimal gain in most settings. So if I think about the current status as we sit here tonight and talk about things tonight, we're still trying to embed those changes. We don't want to revert back to what we were doing 2019, and we want to capitalise on the gains that we've made in terms of engagement of clinicians and engagement of patients. So our HITH literate, non-HITH colleagues, as I might describe them, are really engaged and have a much better understanding of what hospital in the home and OPAT services can do. And with that has come a commensurate increase in the profile of some of the services. The bed demand, especially emergency departments and ambulance ramping, is across the system, and HITH remains an important part of that solution. And I might argue that it's important that we front end that as well. So direct referral rather than just pulling out of emergency department, even better would be to prevent people getting there. There's still a huge variety in the models of HITH or OPAT or community care, and that's okay. I think we're all working towards the same thing. So what we call it or how we structure it and how we financially support it matters less than if we're focused on good patient outcomes and appropriate use of the interventions. I put there the rest of the world is catching up. I think they've caught up. There's certainly a number of countries around the world where, their services are very similar to what we offer. Remembering it's also not just overnight bed capacity, so day infusions, chemotherapy, day stay patients remain a really important part of the puzzle, and there are things that they can be converted from multi-day stay to day-only stay. And really, one caveat, and this will probably be covered in some regards in Kate's talk, is just remember the length of stay. So not keeping people on an outpatient-based program just because you can. That focus on length of stay and treatment outcomes is still really important. And there's a whole conference on this topic, so I'll get in the free blurb there. The HITH Society is having its conference, so our Brisbane audience will be pleased to know it's down at Tweed Heads, so not too far away, later in November. So really, really quick run through of how we've got to where we are today, and really setting the scene, hopefully, for what Lydia and Kate are going to talk about later tonight. And I thank you again for the opportunity to talk to you. Thanks, Ben.
Thanks, James. That was an amazing talk that kind of took us through 30 years of HITH, but also, I guess finished with a lot of really, important directions and issues that we're going to have to cover moving forward. And there were a few comments that you made that I really want to ask about, but I'm going to save that to the Q&A because we've got another speaker